of promoting healthcare, which is equitable and accessible. I won't take too long, but one or two housekeeping points, and that is we'll be having groups of 4 speakers followed by a session of discussion. And Helen, I mean, if there is anything, please let us know about that. So we'll be having a group of 4 speakers followed by a discussion. We'd like everybody to keep within the 3-minute limit that they have been given for their 4 slides, so that we can have time to discuss what they presented, but also bring in, if you like, questions from our colleagues in the audience and try and get them to participate. For colleagues in the audience, I'd like to request that you come on camera and raise your hand so that we know that you've got a question. I'd like to again thank everybody for making time on a Saturday. Some of you have religious commitments as well on a Saturday, and I suppose at this time of the year. So we feel really privileged that you have been able to make your time to share, if you like, your learning with us. We've also got on the panel Professor Neil Turner, who is a professor of nephrology at the University of Edinburgh, and he's the Dean of Undergraduate Teaching and Learning at the University of Edinburgh Medical School. Professor Liz Grant is the Director of the Global Health Academy of the University of Edinburgh, and she will be joining us soon. So on that note, I'd like to hand back to you, Helen, so that we can get the proceedings going. Now, you have a running order, so we'll take the first group of 4 speakers. Thank you.
Thank you very much. I should say that although I'm based in Edinburgh at the moment, I'm actually the Dean of Medical Education and the head of Aston Medical School. Aston Medical School is a very new medical school in Birmingham, right in the heart of the city of Birmingham in the UK, and it's just about to take its Year 3 students. So we're very keen to learn a lot from what other people are doing. And of course, COVID has really hit us hard because we are hardly established and we're already having to change our plans. So without more ado, I think we should get on with the talks. As Ali said, 3 minutes per presenter with 4 slides only. And then every 4th talk, we will stop and have a brief discussion. So we're going to kick off. I'm going to call out the names of the first 4 presenters so that they can be prepared. The first one is Dr. Chowdhury, and then Dr. Mahdi, and then Dr. Masood, and then Dr. Mondial. So I hope that lets the speakers get ready, and we'll take them in that order, and then we will break for a short discussion after the 4th one. Okay, Dr. Chowdhury, who comes from Burdwan Medical College in India, we give you the floor. Have you been able to put up your slides?
Yes, you've been made into a co-host.
Please go ahead.
Good afternoon, everybody. I will be today sharing a study which we have conducted in Burdwan Medical College, teaching clinical skills to first MBBS students in the Department of Physiology during COVID-19 pandemic, a challenge. Continuing medical education during the COVID-19 pandemic has been a great challenge to medical educators. This study was conducted to see the efficacy of teaching ECG in online mode to first MBBS students in the Department of Physiology. There are 200 students in the first MBBS batch in Burdwan Medical College. And our students had to leave their hostels and go home due to the COVID-19 pandemic. So we started our teaching sessions online. Our method of teaching was flipped classroom assisted self-directed learning. We had provided the students with a recorded PowerPoint presentation for their self-studies, following which the students were divided into batches of 20, and each batch had a team leader and a facilitator. The batches were shown videos of instruments, methods of recording normal and abnormal ECG, along with explanation in multiple sessions. Doubt-clearing sessions were arranged for each batch, and these were brainstorming. The students were assessed with MCQ, oral questions, short answer type questions, and problem-based questions. Results of MCQ assessments of students in post-test sessions were much better as compared to pre-test sessions, and the p-value was significant. Results of MCQ assessments of students on normal ECG parameters were significantly better as compared to abnormal ECG parameters. The students performed significantly better in oral examinations as compared to written examinations. We could not assess the psychomotor domain very well. What we advise others, teaching ECG to first MBBS students online is an effective mode for teaching physiology to first MBBS students, but it required more involvement of the faculties. Thank you.
Thank you very much, Dr. Chowdhury. That was,
Thank you, ma'am.
Thank you. That was really clear and to the point and interesting. So I hope everyone can hang on to those thoughts, and we'll come back to talk about them shortly. So Professor Farzana Mahdi, who comes to us from Era Lucknow Medical College, again in India. So Professor Mahdi, are you ready to share your screen?
Yes, sure.
Thank you.
So good afternoon. I will like to share with you the presentation. So what we really did when the classes were disrupted due to the pandemic, suggestions were taken from all the stakeholders, and we tried to focus on teaching clinical skills to our students. So a structured outline was prepared with learning objectives for specific clinical postings in various departments. Blueprinting of various methods, case studies, and materials such as X-rays and instruments was prepared. And with this, we went on with our clinical skill training, and clinical skill was selected, and this was anterior nasal packing. I'd just like to give us a small example. Students were divided into small groups under mentors. Checklist with steps was prepared, and a pre-recorded clinical skill video was shared with the students. Anterior nasal packing was demonstrated online on a bottle gourd, using a bottle gourd after creating a nasal cavity on it. The faculty demonstrated this. Now we shared with the students the requirements for practice sessions, which are the things which were easily available at home. For example, a bottle gourd, Tilly's forceps instead of scissors in case they don't have Tilly's forceps, a gauze piece if they are not having a gauze piece, a ribbon or a small piece of cloth, and instead of an ointment, they could use a Vaseline. So requirements were shared. Now when comes the actual part, so history taken taking was told to them that they need to take the history by doing a role play, by involving one of the relatives at home or some friend or whoever was available. Practice session when they were doing that was under the observation of a mentor. So the assessment part, once they had practiced it, was done using an institutional software which was having all the steps which have been mentioned in the checklist. And once the skill was done, a small debrief or feedback was taken from the students. Now, what was difficult? Difficult was actually trying to motivate the students and their relatives at home for the role play. And what we would like to advise others to do, we would say that encourage students to use materials available at home, mentors and mentor the students, counsel the students, and also giving constructive feedback, and go on with your persistence, because nothing succeeds like persistence. And so this was what we attempted, and what we found, the students were very happy, because up till now they were only having their online lectures and tutorials and stuff like that. So they were a little enthusiastic, and in this way they were able to learn this clinical skill. And the same has been replicated in other departments as well, for using trying to teach them IM injection skills, or certain other clinical skills in other departments. So thank you very much.
Helen, oops.
And thank you, Ali. And yeah, sorry, I was saying, Professor Mahdi, that was really fascinating, and shows the ingenuity of medical educators. What would be really nice is if you could find a photograph of a bottle gourd while the other presentations go on. If you had a picture, if you had a picture of a student doing it, it would be even more fascinating, but that might not be possible.
Sure.
But it just shows what you can do with things at home. So thank you very much for that. I'm sure we'll talk about it in the discussion. Now we move to Karachi, Pakistan. Dr. Sadia Masood is going to speak to us from the Aga Khan University in Karachi, Pakistan. Hello, Dr. Masood.
Helen, could I just add, we were hoping to have Dr. Masood. She has tried her best, or she was trying her best to come in. Karachi has seen massive flooding and there have been power cuts. So we do live through strange times, don't we? COVID, flooding, hurricanes. So do we have anyone else from the Aga Khan University in Pakistan who might be able to talk about their experience there? Because we'd really love to hear from people in Pakistan. It appears that we probably do not have somebody from Aga Khan University in Pakistan, so we'll move on to the next speaker. And our thoughts really do go out to Dr. Masood at this time, and we hope that she, her family are safe and will be able to join us some other time.
Yes, yes, Ali, you're right. I do recall seeing some awful flooding on the news last night. It's very difficult for some people to have to live through that. So we will move on, and our next speaker would be Dr. Mondial, who's coming from Calcutta Medical College, Kolkata, India. Can I also ask for Professor Dua Elmores to be prepared, and we could bring them in for our fourth in this group? If Professor Elmores can be getting ready. So over to Dr. Mondial from Kolkata, India. Welcome.
Of course. Dr. Mondal, you're a co-host now. will it be easier to run Dr. Mondel's slides?
Thank you. Thank you. I'm very obliged to be a part of this program held by the University of Edinburgh, the Global Health Academy. Thank you, Dr. Helen and
We've lost you, Dr. Mondel. Can you hear us?
Okay, I think what we'll do is we'll go to Dr. Dua.
Hello. Am I audible?
You're back again.
You're back now, Dr. Mondel. We missed you for...
Yes, I'm.
You're back.
Yeah. Thank you. Sorry for the interconnectivity problems. Thanks, University of Edinburgh. Thanks, Dr. Helen and Mr. Ali Mehdi, sir. Now, today the topic of my discussion is jigsaw technique. Now, I will just yes. So we had conducted Jigsaw online learning method at Calcutta Medical College. Now this was a cross-sectional sectional study and interventional study here at the Department of Community Medicine. I had taken 100 students and they were divided into two batches of 50 each. And they were allotted to a traditional teaching online method, that is the Google Classroom, as well as the YouTube classrooms, and the other half was allocated to Jigsaw online teaching learning method. The IC clearance was taken and the questionnaire were validated.
Sorry, Dr. Mondal, we've lost you again. Can you hear us? I think we may have to move on.
Dr. Mondal, could you switch your camera off? I think the connectivity will improve if you do that.
Yeah, I think so. Yes.
With your permission,
yes.
Can we run your slides, because it'll be easier and all you could do is talk and say next. Perfect.
Yes, sure.
There you are.
Great.
Yes, thank you very much. Thank you, and I'm sorry for the we'll go for the next slide. So can we have the next?
I'm sorry, Dr. Mondal, we're just not hearing.
Hello, can we have the next?
We're not hearing what you're saying, I'm afraid. Even with your camera off and Ali showing your slides, you're just breaking up so much. It's impossible to hear. So I'm afraid we're going to have to move on to the next speaker, and whether you might be able to contribute later on in the discussion if things are a bit better, then that would be great. And it's such a pity, because the Jigsaw method sounded so fascinating. So I hope you'll be able to join in the conversation later this morning. But can I ask for Professor Doa Elmores to share your slides? Professor Elmores is from the Mansoura Faculty of Medicine in Egypt. Good morning, or good afternoon for you.
Good afternoon, all. It's a great honor to be with you today. I will exchange the experience of my Faculty of Medicine, as I am in academic department. So I don't have an experience in clinical teaching online, but this is the experience of my faculty. Will it share the screen? Okay. Is it visible?
Yes, it is.
Okay.
Yes, it is.
Okay. So the update on change in clinical teaching during COVID-19 at Mansoura University, Faculty of Medicine. First of all, I'd like to start with this quote. It is about educational response to the crisis are capable of changing the meanings and purpose and values of the school and also the faculty as well. What we did, this is the outlines today. What did we do? Why did we do this? And what went well and what could be better? What did we do? Due to the COVID-19 pandemic and the lockdown, all the learning process was suspended all over the world. The lectures, face-to-face lectures were recorded as video PowerPoint and uploaded on the Moodle, while the practical and the clinical skills are suspended, and some of practical skills were recorded on the jars as videos and then uploaded also to the students on Moodle. Why we did this? Because for clinical teaching specifically in most of departments, especially pediatrics and obs and gynae, there is no other alternatives rather than face-to-face learning, except for simulation-based teaching in the skill labs. Some staff recorded the skills on the mannequin as skills lab and then uploaded the recorded videos on the Moodle for the students. Some departments like medicine and surgery have another options rather than skills lab in the form of virtual patient for some cases for medicine department. And also there are the use of Insurgent Academy offered by the Egyptian Knowledge Bank. Here is the website for the Egyptian Knowledge Bank and the Insurgent Academy. It has a lot of material which is free for students to log in and then watch a lot of videos, educational videos and guidelines and other material. Also, what went well, the rapid response of the staff to deal with the change and the intention to buy a virtual patient software by the administration to help in the future clinical teaching. What we advise or what could be better, I think to have a contingency plan is very important, as we always thought that nothing wrong will happen. And when it occurs, we are frustrating and don't have alternatives to continue our learning process. So it is a must to have a contingency plan and plan B or C, how we will continue if other outbreak of COVID-19 occurs. Also, we should think about different methods. As we said in Mansoura Faculty of Medicine, we were preparing to buy a software for virtual patient to help in clinical teaching in the future, inshallah. Thank you so much.
Thank you very much for that, Dr. Morsi. So we've had 4 speakers, and we're going to pause now to ask for comments and questions. And I think Neil's been looking at the chat and will bring some questions from everyone's thinking. First of all, can I go back to Professor Mahdi? Did you manage to find a bottle gourd?
Mr. Mahdi, we've unmuted you, sorry.
Yeah. So I was able to find my this bottle gourd, and Dr. Raza will just demonstrate it. It will take half a minute. Dr. Raza, please go ahead.
Yeah, so we can carve out a nasal cavity on this bottle cup using just a regular knife.
You can make 2 small triangles, and this.
So that's okay. That's a bottle gourd, and you can make a nasal cavity in here. If we had
This
a
is
little
the
more,
septum.
this is the nasal septum, and
In the middle, you can see the nasal septum, and you can carve it out a little more to create a little better. And then
you can use a piece of cloth and scissors to, stimulate Tilly's forceps. And then,
using an ointment or anything,
Vaseline,
which is present
in, then you can just pack the nasal cavity using the, okay, just 1 second. It's not carved out actually.
Very good. Thank you very much. That's given us some ideas. Our main problem in the UK is to get some bottle gourds. So perhaps you could
use an eggplant or anything which is available, on which you can carve out a septum. So this is one of the clinical skills. The reason why I tried to give you from starting from the entire module, so you can replicate this model for teaching any of the skills, in any of the subjects. So thank you very much.
Thank you very much. So I'm interested to know how many people have been doing skills like this. How many people are not just doing skills over videos, but actually using everyday objects rather than mannequins?
Hands up, anyone on camera? A show of hands. It doesn't look like there's a show of hands.
Okay.
Oh, right. We've got a show of hands. 2 people have raised their hands. We'll see. So Lakshmi Achanta and Karthik Balaji. Karthik Balaji and Lakshmi Achanta. Could you please come on camera? Go ahead. Dr. Lakshman, go ahead. Tell us about your experience.
Yes, I want to ask to that Farjana ma'am that she tell that she used the software for the assessment of the student. What is the basic content of the software for the clinical assessment of the students? How can we assess the students of their clinical skills?
Actually, I had mentioned that we were using a checklist. A checklist was prepared to teach and also assess. So this checklist is fed, the student logs in, and then, answers, attempts that the questions given in the checklist, and then it comes to us and we can assess it. So it's an inbuilt software which we are using for teaching and training, and we give MCQs also on it.
Can we assess from that software the clinical skills also, like spot stations?
No, I'm saying using that checklist. So if a checklist is saying, giving various steps. So if the student is able to, answer correctly in the checklist, using that, checklist, the steps involving that skill. So this is how you can just, assess that portion.
Thank you, ma'am.
Thank you, Dr. Lakshman. We've got two people raising their hand. Helen, over to you.
Yeah, Dr. Balaji.
Dr. Balaji, you're on.
Dr. Balaji, we can't hear you.
Madam, I would like to tell innovation which was taught to us by my pathology professor. We didn't have much resources in our college when I was doing UG in Tamil Nadu Government Medical College. So to do simulate breast mass, so he used to bring a cotton. Inside it, he will place a lemon. So, and will give a syringe and ask us to palpate exactly where the lemon, which is simulating a mass, and hold it, how to prick and how to withdraw the do the biopsy. He used to do that. Or when it is a hard mass, he used to place a small potato. So he taught us the biopsy skill, not with the patients, but during our second year with this like a simulation using vegetables. So I thought of sharing it. Thank you, madam.
Yeah, we do. We need a really good collection of all these ideas, and it's yeah. Maybe the experience with the pathologist would now inform your thinking of how to translate it for clinical teaching. So we've seen how clinical teaching can be done focusing mainly on videos, so for the transfer of information, and using household goods to practice. Now, I know there are more people who would like to speak, but we're already behind time. So I'm going to suggest that we move on, but that doesn't mean that people won't be able to bring those questions to the fore. And we'd really encourage you to type questions into the chat. And then we're going to try to pull them together and answer as many as possible from the speakers. In that way, it might be more efficient. We might get more through more questions. So please do that. Meanwhile, I'm going to move on and ask Dr. I'm going to call out the next 4 speakers so that you can be preparing. So the first one will be Dr. Selvaraj, and then Professor Venkataraman, and then Dr. Abutahin, and then Dr. Imam Habibi. So that's the next 4 we're going to hear from. And I'm really sorry if my pronunciation isn't as slick as it should be. But we now turn for another speaker from India, Dr. Kokila Selvaraj, coming us from the Medical College and Research Institute in Kanchipuram in India. Are you able to share your screen and show your slides, Dr. Selvaraj?
Thank you, madam. Can you share the slides?
Great, thank you. Welcome. Please go ahead. 3 minutes and 4 slides.
Are you able to the screen?
There we are. Yes. Can you make it bigger?
Yes.
Full screen for the slides, please.
Good evening, one and all. Thank you for the opportunity given by Global Health Academy, University of Edinburgh, to share our experiences, what we made in the clinical teaching for medical students during COVID-19. The curriculum for medical education is designed for on-site campus learning, but suddenly we were forced to switch over to the online mode, in which the faculty, the students, and the institutions were unprepared. As a faculty in the Department of Community Medicine, we used to train the 7th semester students of MBBS for clinico-social case presentation, during which time we used to demonstrate cases like hypertension, diabetes, acute respiratory infection, tuberculosis, like that. We tried online teaching with simulated patient for a batch of students with 12 in numbers. We trained one of our intern as a simulated patient for hypertension. We trained her to give history as 50 years of age with 2 daughters, attained menopause, unemployed husband, working in busy IT company, known hypertensive for 2 years, not a known diabetic with family history of hypertension, history of consumption of food with more salt, rich in fat and poor in fiber, and not doing any physical exercise or meditation or yoga. The students elicited this history from the simulated patient through the phone the previous day. In general examination, the student asked for height, weight, waist circumference, blood pressure from the simulated patient. As already trained by us, she gave the values which will come as obesity and increased waist circumference. The next day, through Zoom class, the presentation was made by the student in the presence of faculty and all the students along with the simulated patient. We discussed about modifiable and non-modifiable risk factors for hypertension, discussed little about drug treatment and compliance, but mainly on non-pharmacological therapy, lifestyle modification. The positive aspect of our clinical teaching was we were able to impart cognitive aspects of hypertension like classification, how to prevent hypertension in the family, in the individual level and in the community, history-taking skills, and we were able to observe the communication and counseling skill of the student. The student was telling the simulated patient about the DASH, that is dietary approach to stop hypertension, as well as he was counseling the patient for adopting the regular physical exercises. We got the positive feedback from the students. The limitation of our online teaching was we were not able to impart the psychomotor skills like taking blood pressure, waist circumference, height and weight. This method cannot replace the bedside teaching. Of course, we had few technical issues because of the poor bandwidth. What I want others to do is, actually we could have improved that with supplementation with the video presentation of the clinical examination, and we could have demonstrated from the department itself using some other staff. We could have got reflective assignments and narrative threads from the students because they are smaller in number. Our future plan is to train more number of simulated patients for other cases like mother of under 5 child, diabetes mellitus, tuberculosis, like that, and we will supplement it with video presentation. This is a small piece of clinical teaching done by the Department of Community Medicine from Meenakshi Medical College and Research Institute. Thank you for the opportunity to share this small clinical teaching. Thank you.
That was very nicely presented and a very nice example, Dr. Selvaraj, of really history taking, but history taking focusing on sociological aspects. And that's often a very dry subject. So to actually put it into a clinical setting in the time of COVID, fascinating. I'm sure we'll have questions about that. Thank you very much. Let's move on to Professor Venkataraman, and this is coming from the University of Kuala Lumpur in Malaysia. So Professor Venkataraman, are you ready to share? Great. Thanks very much. Can you put the slides onto full screen?
Yeah, I'm trying to. It's not going on.
Don't worry, if we're seeing quite well as it is, so that's fine. Another reason never to have too much writing on any one slide.
So now it's on full screen, is it okay?
It's not showing full screen on ours, but it's fine. Please carry on, we can see.
Okay, so thank you very much for giving me this opportunity. So this is from University Kuala Lumpur in Malaysia, Royal College of Medicine, Para. So I just wanted to update the changes that we made. So this is the outline of my talk. So no conflict of interest. So ours is a program which is outcome-based 5-year MBBS curriculum on a SPICES model. All of us have at least 30% of blended learning, even in the pre-COVID era. So the transition was quite easy during the COVID era. MC was introduced on March 18th in Malaysia, but we continue.
We can't actually hear you. Are you able to switch off your video and see if we can hear the voice?
Oh, okay. So
we can hear you now. It just disappeared for a while.
Can you hear me now?
Yes.
Okay. So can I continue?
Yes, please do.
Okay. So we continued with the preclinical teaching, which was online. And then a training was given on Microsoft Teams to all the faculty and the students. And the theory sessions were completed initially. We had one last group of 5th year students and 2 groups of 3rd year students. So it was all done on Microsoft Teams. But the clinical sessions were deferred because we thought that they should be going to the hospital rather than do anything online at home. So, but the clinical skill videos were already posted in our learning management system, so they could have a look at it during the waiting period. And then after the green zone, the hospitals were open to clinical teaching. Then we had a year 5 and year 3 clinical postings. Normally we run them concurrently. This time we ran them consecutively. So we were allowed only 5 students to access the ward at any given time during this with COVID precautions. So they had to wear a mask and then use strict hand hygiene and also have physical distancing. From July 6th, we started the bedside teaching for the 5th year students, and observed long cases were also done during this time because that is a compulsory for prerequisite for them to sit for the final exam. And then this month we start with the year 3 students. So history and discussion part, we did it outside the hospital. History, they had already clubbed the children. So, and then the discussion also was done outside. Only the clinical demo was done in small groups in the wards. So the year 3 was also have some skill videos to be posted with reflections in our e-portfolios, followed by feedback from the faculty. So they go to the clinical skill lab and they do simple things like taking the weight or the length or the height of the child and also the head circumference, and they post it along with the growth charts and then their reflections. And then we give the feedback to them. So why did we not plan to do online skill sessions? So we thought authentic clinical teaching and assessment was mandatory. So it cannot be replaced by any kind of simulation. And for the hospital to avoid crowding, we used only 5 students at a time. And even in the evenings, only 5 students were allowed to go and see the children in the ward. So the clinical postings went well despite the restrictions. The students showed good teamwork and time management skills. What could have been better? The number of people in the ward were very many, not very many, limiting clinical exposure in the COVID era. So what we would advise others, I mean, this is what we did, that our academic leaders decided not to compromise on clinical teaching and assessment. This is based on the Malaysian Medical Council directives and also thinking about our stakeholders, the future patients of our graduates. So these are my acknowledgements and thank you very much.
Thank you very much. So that was really describing to us how you continue with a clinical placement with some restrictions in the time of COVID. So quite different from some of the earlier talks. We're now going to ask Dr. Abutahin from Karbala in Iraq to speak.
Thank you, Mr. Chairman.
Can you share your screen?
Yes.
That's lovely. Thank you very much.
Is my screen clear, my voice?
Yes, thank you.
Thank you for giving me this opportunity. Thank you all. Thanks to previous speakers who cover an important note. Now I will talk about what we've done in Karbala College of Medicine. Karbala College of Medicine in Iraq was started in 2004, and we follow a PBL approach in learning since 2013. When the pandemic started, it reached to Iraq in cases in late February. In March, all universities, college, schools were closed, and we stopped for a month or more. Then it seems that the pandemic will continue, so we start to the decision was to go to online teaching and learning, and we shall start. We try to cover the theoretical part actually in the beginning. Most colleges start with that. We hope that what was thought that the pandemic will diminish with hot weather, and in summer everything will be settled and cases will be go, and we can return back to our clinical teaching and to compensate that. But what happened that in summer the cases had increased. So actually we have little experience with online teaching and learning. Not all teachers, not all students, but we have to. It's a must. It's not a choice actually, because we cannot continue the academic year without online teaching and learning. So it's an applicable and good solution. Theoretical subjects, as I said, mainly clinical training were covered through case scenarios, discussion, and videos that become late in May. We start, but the cases are still rising in Iraq. Now we reach 4,000 cases a day. So even till now, we cannot bring the students back to hospitals or PHC centers because it's already filled with COVID patients, and it's a risk for all. It's not applicable till now. The application of online teaching at the beginning was a trial, but when we go in, it's become smooth. Everything went well, especially regarding the theoretical, giving lecture, upload it on media, or make online session with the students. We enjoyed that. We became have a good experience with using Zoom, free conference call, Google Meet, and other approach. Same for PBL sessions. PBL sessions maybe in the beginning was difficult, but after a while it's become smooth. We run a good small group discussion, a good interaction from students and teachers, and it runs well. The problem mainly is with the clinical teaching and in assessment. Teacher and tutors are greatly developed and upgrade the skills. This is one advantage of online teaching and learning the experiment. What we could better, we hope that the university website was more developed. It's not that it's new, not well, little experience from staff, little experience from staff. So we go to other such as Google Forms or Edmodo because it's need the teacher center. The lecturer can control it rather than an IT or central management of the website. Teachers were trained in e-learning, internet coverage, and it's a big problem actually. I don't think it's only in Iraq, but in Iraq it's a major problem. So we cannot upload any video during Zoom or something. We cannot, and there is frequent on and off with the internet or the electricity that affect a lot on a clinical. And even in this session, it happened with us a lot with many colleagues. Two main challenges appear. The main two challenges we have actually is the clinical and practical training. We have it's difficult to cover. So whatever we do, we cannot have the teaching or assessing the attitude, the direct communication of students with patients. How do they the exam? How they communicate with the parents, with the relatives? We cannot judge how do they learn this to conduct the skill. So e-learning is important, can cover something, but it cannot cover all the issue. We still have a major defect in clinical and practical training. We should try to compensate. The other issue is the assessment. Assessment issue also is difficult. It's whether theoretical or the clinical assessment, formal or summative, all have difficulties to control through online, difficulty to assure quality assurance. Another problem that we have lost the cooperation of staff from health facilities from outside the college of medical schools. We have many colleagues who were teaching with us students when they go to hospital. Now they can't. They have little experience with online learning, as well as they're already busy with COVID patient, with COVID pandemic. They are we are in fight with the disease for 6 months, so they have no time, much time to give to teach students, and they have little experience with online teaching and learning. So it's become overload on the original staff of the medical college. This is another issue that we face.
Abutahin. I think, can we just read this briefly and then close, because we really must move on.
Okay,
3
I will.
minutes. I think you've really got across to us. Iraq has a really serious problem because that you have too many COVID patients to permit students to enter. It's a complete contrast to the last talk where we're hearing that students could go into clinical placements. Things for us to think about. Can I ask people to be thinking about what determines whether or not you let students into your hospitals? At what criteria are you looking for? Maybe that's something that would be useful to discuss at the end, because we're just hearing how some cannot let any students in and others are letting everyone in, but in small numbers. Dr. Abutahin, thank you very much for sharing that with us. If I could now ask Dr. Iman Adibi from Isfahan in Iran to speak to us.
Thank you.
Dr. Adibi, could you please come on screen?
Can you share your screen?
Dr. Iman? Dr. Iman. Dr. Iman, we'd like to see you on camera. There's one person called.
Dr. Iman?
Yeah, co-host.
No?
We can't see Dr. Iman at the moment. Dr. Iman's on camera. Okay, good.
Good afternoon. Good morning.
Hello.
Can you hear me?
Yes, we can hear you. Thank you very much. Please share your screen, and we're looking forward to hearing your talk.
Okay, I would ask Dr. Ali Mehdi to share my slides for everyone, because that was some problem with sharing slides.
We'll do that, Dr. Iman.
Okay, shall I start?
Yes, please.
I'm Iman Adibi, Assistant Professor for Neurology and Vice Dean for Education, one of the university hospitals of Isfahan University of Medical Sciences from Iran. Some changes in the clinical teaching during COVID-19 pandemic in my institution were at the beginning similar to many other universities, reactive response to the public health emergency in compliance with national health policies and high-level steering recommendations. So at first, all in-person education's clinical rounds have been placed on hold. Online platforms for distance learning were introduced to faculty members, and a few weeks later, accounts for webinar hosting platform were also provided. All clinical departments were encouraged to switch from the traditional methods and plan for virtual education, uploading courses to the university e-learning platform, or holding live sessions using digital media. In our hospital, we have equipped classrooms and faculty offices for live online sessions as well. Next slide, please. What went well? So clinical departments and their faculty members got soon familiar with the virtual education and acted creatively. They had online morning or evening reports, case presentations, and webinar even at unusual times, late afternoon. Teaching materials were distributed effectively through digital media, and there was growing number of extra curricula, but educational activities by faculty members and medical students themselves through WhatsApp or Instagram Lives. And infrastructures of e-learning developed rapidly, and then the managers began to implement some curriculum changes. But what could have been better? Next slide, please. Learning videos for clinical skills education were lacking, in online exams in matters of security, validity, and reliability, and also our internet websites. And a very important thing, mindset of senior teachers and managers about enduring value of clinical teaching and during this pandemic could have been changed. Shared decision making with contribution from faculty members and medical students, and what we advise others. Next slide. I think university hospitals as a main field of clinical teaching should be prepared for virtual medical education and e-learning. They should organize advisory committees and task force, including faculty members and medical students. Clinical teachers should be supported by medical education experts and IT technicians. And the most important fact is that curricular adaptations should be flexible in terms of delivery and administration. Thank you for your attention.
Thank you very much, Dr. Mann. That was very clear. So you also have used the clinical setting, but in a limited way. You and the previous speaker, Dr. Abutahim, had mentioned the difficulty with exams. So I just want to say that in a month's time, we're going to run a session like this, and we're going to focus on assessment. And again, we are looking to hear what everyone's been doing for assessment and some of their successes and their difficulties. So that's why we are not going to focus on assessment this time, even though we know it's a really important subject, okay? So we'll look forward to that in a month's time. But you've been doing clinical rounds, and what I'm hearing repeatedly, we're now at the end of the next batch of 4 talks, so we just want to pause and reflect and pick up your comments and questions. And what I'm hearing is that several of us are trialing teaching at least history and communication through the online medium, but we are struggling to find a way to teach examination skills, let alone the very practical skills. And I'm wondering, first of all, if we just think about history taking and communication skills, how many of you are doing it with your students at home, and how many of them are actually in the university or the hospital campus? Are you having to deal with the fact that they're away from a learning environment, they're in various types of home setting? What's the experience at the moment? Are you doing remote online teaching or university hospital-based online teaching? Can you maybe show a hand for those of you whose students are still at home? Are they still at home?
Yes, they're still at home.
Still at home.
Yeah.
And others? Still at home?
Our students are back. The clinical students are all back.
They're all back. And Dr. Abutahi?
They are at home only.
No, they are at home. They are at home.
So a real mix.
So a real mix. So a bit like us in the UK at the moment, we have some students at home and some students back. But the hope is that by the end of September in the UK, we'll have most of our students coming back at least to campus, if not having in-person teaching.
Yes.
Is that the same across the world?
It's related to pandemic situation, if you will. It's related to pandemic situation. So its cases are decreased and very low in UK, in other European countries, but in other areas such as India, Iraq, still the pandemic is in the peak and the cases are rising. So it's related to the pandemic situation, as I think.
So in Iraq, still at home. In India, our speakers from India, is that right? The students are still
at home only. They are at home. I don't think they will come back in 1 month. It will take some more time.
Some more time. So that's even more difficult when you're dealing with variation in bandwidth and home circumstances and all the rest. But on the other hand, it does give opportunities. So I was also wondering how many people, when they're teaching, particularly history taking, how many of you are encouraging students to do that with a relative in front of the camera and be observed and critiqued? Does anyone have experience of that? Does anyone want to speak?
Dr. Malik, would you like to come in?
Yes, thank you very much for the opportunity. What we did was we used videos, but not our videos from the students. So I had a session with the students, for example, on examination of clinical, the cranial nerves, and we explained the steps and whatever I could show on the screen I showed. And then I asked the students to do this examination at home on a relative or a friend, make a video and send back to us. We had a little competition. The winner would win a Kit Kat. And then we showed these videos online to all the students and got feedback from students on each video. And it was really a fun. I can give my feedback and students can also give feedback on that video. And I think we enjoyed the session and I got a very good feedback from the students. Of course, we cannot equate it on face-to-face, but I thought we did do well on this aspect.
That's interesting. It must take quite a lot of organizing to do. But again,
it's not difficult now because students all have their handphones and they can make videos so easily, and that can be sent by WhatsApp so easily. So
yes.
I think they enjoyed it. They enjoyed it doing these sessions.
It may though become a problem ethically or with respect to confidentiality for relatives, depending what you're examining, particularly for examination skills. Does anyone have experience that they want to bring to us all about that, coping with how do we teach examination of the abdomen or the chest when we've only got relatives? I mean, the knee and the ankle may be okay, but what about these other areas? How are we dealing with that? I think that really is the difficult area, isn't it, that we're struggling with. And maybe as we go on, we'll hear some. I think Neil Turner wanted to ask or bring forward 1 or 2 questions from the chat.
Yeah, I just wanted really to highlight both in the chat and in what people are saying, the enormous value of sharing these different ideas and experiences. quite a few people have clearly pushed their expectations of when their students are going to get clinical experience further down the line. Our worry about that is that it's not at all clear that things will be easier further down the line. So I suspect that we may be looking even harder to see how much we can do without having the students in a clinical environment. And I just think it would be really, really helpful to, and Ali, I think we might speak about this afterwards, to have some kind of place for sharing ideas beyond these meetings even, packing the nasal hemorrhage from a gourd, or how to suture an orange, and maybe we need to send the students some equipment at home to do some of these skills on camera. And I think this issue of moving to examine real people in front of the camera would be a real step forward in terms of what we were able to teach the students without having them there. So if people have solved the privacy concerns and so on around that, I guess there's no problem if the relative is happy and volunteers, but they may be slightly concerned about other students sharing it. You know, there's all sorts of potential pitfalls there, but real stories of how it is actually run would be incredibly valuable.
I see Dr. Saravana Bava has the hand up, and I don't know whether Ali can give Dr. Saravana Bava a microphone.
You can actually.
Dr. Saravana, could you please come on camera and we'll be able to locate you more easily. Whilst we are speaking about that, yes.
Yeah, am I audible?
Ali, you've gone.
Am I audible?
Yes, yes.
Am I audible?
Yes.
Yeah, I'm Professor Dr. Saravana Bava from Tamil Nadu, India. So we had conducted the history taking through the Zoom. So we had a real patient, and I asked my postgraduate to interact with this patient, and everybody of the students who are there, they were at the home, they were listening to the interaction, the history taking what the postgraduate was taking from the real patient. They were all listening on online, and after the history taking, we had taken the photos of this patient and posted them again on the online, and I used the Blackboard to explain them, and also interrogated through the Zoom how else, what else the history would have taken, how else they would have, what was the things which was missed, how they went about, how they should have got better. And I also posted the photos on the online and showing the features of this patient's nature. I'm an ophthalmologist, so I posted the cataract scenario, real pictures from the patient. I explained what were the changes occurring in the lens, and also I used the Blackboard, which is again focused by the camera, and I taught them on the Blackboard what they should have thought, I mean what they should have seen, when what they should have, what they missed, how, what else they would have picked up on the history taking. That's how I went up. I wanted to share you that.
That's very interesting, because then not only are you giving feedback in real time, you
Yes.
are you recorded the history taking, and
No,
then,
madam, it was on the online. It was the direct, online. Patient was there. My postgraduate, who is a medical, ophthalmologist doing her post-graduation, she interrogated with the patient. Everything was online. And
Yes.
the undergraduate students, MBBS, they were listening from the home.
but it does make me think that you could record a Zoom session like that and put a narrative critique up beside it for the students to think about later as well. So sometimes the technology gives us even more ideas of how to teach. We'd better move on, I'm afraid, to the next batch of speakers. And the running order is going to be Dr. Mike Silva, then Dr. Shital Bandari, then Professor Chalam, and then Professor Thomas Chackle, please. So we're going to start with Dr. Mike Silva. from Oxford. Are you able to share your screen? Mike?
Yeah.
Yeah, great. Thank you very much.
Good. I hope I'm audible as well.
Yes, you're audible. We can hear you very clearly. Thank you.
It's fascinating to listen to how people are coping with the pandemic around the world and the innovative techniques being offered. Thank you very much for having me today, Ali, and Global Health at the University of Edinburgh. I'm about to give you just an overview of what we've done in Oxford with regards to clinical teaching, and would be happy to take questions afterwards, provided I'm still around because I need to be elsewhere very soon. So what changed? All lectures and teaching moved online very quickly in the latter part of March 2020, and there were no clinical placements up until July of this year. And obviously we are going to discuss assessment at another time, so I'm not going to talk much, but all our assessments moved to either open book exams taken at home, and there were some changes to how we assessed from formative to summative assessments and so on. There were lots of lectures that were given routinely to students in the old format that then were changed to replicate what was done previously in order to get back to speed and make sure that the students were getting the lectures that they were missing otherwise. But what happened more importantly was that we spent a lot of time risk assessing students, making sure that they were not at risk at COVID. And also the hospitals moved into green and red zone. So there were some hospitals where we treated COVID patients and some hospitals were kept very strictly COVID free. And that resulted in us being able to then reopen clinical teaching for even the students who were considered relative risk for infection and complications of COVID. And that we think was a game changer with regards to moving to the clinical setting. But even so, we've limited the number of students per teaching session for ward rounds, and bedside teaching has been stopped completely. We moved to using communication skills very routinely on a weekly basis to students, so that examination, interaction with patients could be done remotely, and this was largely appreciated by, or greatly appreciated by, the students. So what went well? I mean, Oxford and Cambridge is unique because we have a collegiate system. We have colleges where students have tutors, and in my college, for example, I had 7 students per year, and teaching was 1 in 7 to them on a very regular basis, and myself twice a week for these students. We find the time for them, and that we keep moving around depending on how busy I am, and this is just giving my experience as an example. The university itself centrally worked by signposting where students could go to get their teaching, in other words, benchmarking what we thought was of quality. And a good example was the Royal College of Surgeons, Edinburgh, had weekly, bi-weekly webinars for them. And there's an app that was developed by the Brighton University called Capsule, which we signposted students to go to. And also there were lots of doctors who were volunteering their time to teach, because they were also doing different job plan patterns and found time to actually get involved. So again, we help them facilitate their enthusiasm towards getting the teaching done. When the students came back, I will discuss that in the next slide. The lectures themselves were then moved to an online series, and these were of very high quality and therefore were well received by the students. At the same time, the university kept informing through the colleges as well as centrally as to what was safe and what was not safe for the students to do. In other words, making them more secure in their environments. And like I said previously, the communication skills was really well received because that was very routinely done and very effectively done. What did not go that well, there was initially a lack of communication as to what should be done and what should be happening, especially in the early days, March, April, because I think even the university was not aware of what was safe and what was not. And for that matter, even the government. So that was, there was a lack of clarity at the beginning. The clear disadvantage we still have is that students are limited in numbers for ward rounds. And we had special study modules that started with a subject matter that's covered over a duration that ends up with OSCEs and assessments. That has stopped and there is no obvious replacement for that. And most of the teaching happened through the colleges. So until the lectures started to kick in, there was a bit of disconnect between the central university and what was actually happening. And although it was announced that the lectures would start, it took some time to actually get off ground, and that also was something that could have been done better. Additionally, you found that clinicians struggled to use technology when they first got going, and this I don't mean using Zoom. It was actually getting students to join us at MDTs. The MDTs were conducted using MS Teams, and usually MS Teams is a bit more restrictive in how they let people in to join, and therefore students found that they were being kicked out of these and not being able to join. So that was another issue. What could we have done better? I think there isn't uniformity across the colleges, and that could have been better policed by the central university. Also, there was no direction as to what should be done and what should be covered until very later on, and that again we could have done better. And I think what hasn't still happened is that the university hasn't really acknowledged that there has been a lot of voluntary work done by a huge amount of clinicians who have just come forward and helped out. And I think that really should have been an improvement. So that's in a nutshell what I could give as an overview as to what happened in Oxford or is happening.
Thank you, Mike. That's, again, quite a different offering. And as you say, giving an overview of all the different components in a clinical school. So that was really interesting. Thank you very much. I think now we should move on to our second speaker in this group of four, Dr. Shital Bandari, coming from the Patan Academy of Health Sciences in Nepal. So Dr. Bandari, are you able to come on screen and share your screen with us?
Can you see it?
Hello. Yes.
Hi. I'm sorry, I am having another round of power cut here. I am in the data today. So today I am going to present a few slides from my institute. This is something that I have prepared with my dean, who is also here with us. Dr. Sijana is also here. I am not able to, yeah, it is here. So I would like to share what we have been doing in the MBBS. So MBBS is considered as a college degree. So government of Nepal has suspended all the activities. So we do not have a student with us at the academy now. All our classes has been, now we are doing it online. Even the PBL is doing, we have been doing it online. So everything is going very well, but there are some complaints from the student that some fatigue is there. The online fatigue is there. So we are giving breaks in between for them. So they are writing to us, and Dean is very considerate. So we are giving after every module, there is a 1 week break for them. and we are having a lot of feedback, taking a lot of feedback with them. But what we are doing is continuous assessment is ongoing. So whatever we can do online, we are doing it. Our field posting, that is a very important part of our MBBS teaching, because 25% of the curriculum is our community health sciences, or otherwise known as the community medicine. We have been doing it virtually with the help of the vast number of students that we have now in all over Nepal. Our graduates, they are helping us to run the courses. Okay, so our graduates are our faculty now. So they are actually holding our hands, and they are helping us on that one. So what we have suspended is practical classes and bedside teaching. In the MBBS, we have not been able to do that. Interns have come back to us. We are running the internship. They have already cleared the MBBS license exam. They are ready to practice in Nepal, and we are training them in the COVID as well as non-COVID wards. We are training them because the mandate for PASS is to train the student and send to the rural and remote areas of the Nepal. And now the Ministry of Health has already dispatched many of our graduates to the needy people of the Nepal. And we are very happy with that one. And our students are taking the responsibility because we were able to train them appropriately in our hospital. PG, we have never stopped. So from the day one when the COVID struck, we were training them at PASS. So they are working with us. We are having regular classes with the PGs, and we do whatever we have been doing before COVID. So they are working with us in the COVID and non-COVID wards. So PG teaching is going, but especially in this COVID ward, internal medicine, pediatrics, and GP residents, they are working very hard. Currently, there is a second wave of COVID-19. Second wave is here in Nepal. And yesterday in Kathmandu, 50% of the COVID cases in Nepal was from Kathmandu alone. So we are having a lot of patients, we are having a lot of difficulty, but our PG graduates are helping us day and night. We are working for that one. So once the PG are graduated, the government is planning to send them as a specialist in the rural and remote areas of the Nepal. So at last, what we have been doing, so January 22nd was the first case imported from Wuhan, China to Nepal. Yesterday, there was 36,456 cases and 195 deaths. Around 20 of our staffs are already infected out of 1,500 staff. We have 100 bed isolation unit, and I have been told that we already have a 21 bed ICU, and out of them, we have 15 ventilators only. So we have, with all our clinicians, our students, we use the PPEs produced by PASS. Our IPC committee produce the PPE and they ensure the quality. And we have a very, very low infection, COVID infection in our country. So Hospital Incidence Command Center is working very, very closely with the government. And we are giving all the data, all the feedback that we are getting from our hospital. And we are very happy to work with the National Health System. So thank you very much. This is all from my side.
Thank you very much, Dr. Bandari. I think we'll just move quickly on to the next talks at this stage, and we'll come back and ask questions. Again, can I encourage people to put questions in the chat so that we can pull them out and quickly get the speakers to address them at the end. So turning now to Professor Chalam from Bhaskar Medical College in Hyderabad, India. Hello, Professor Chalam. You're mute at the moment.
Yes.
There we are.
Yes, I have been unmuted.
Yes.
Good evening, everyone. Here it is the evening for us, and I request the organizer to allow to share the slides. Can I share the slides? Can I share the slide? Okay, the slide sharing is not coming.
You can, Professor. We'll make you a co-host. Sorry, we missed on that.
Okay. So I'm going through all these presentations, and I definitely feel that nothing much can be added, because in our college also the same thing. We have gone online classes, and online classes are going on, and same thing, assessment, Google Classrooms, MCQs, everything is going on as it was being told by other speakers. And we in our college also, this teaching of ECG, physical examination, clinical teaching, all that is going on in this. As you told, the practical skills, the procedural skills also is being taught online. What I felt is, I was really felt that the most important challenge is teaching procedural skills. The online teaching is okay for cognitive part, and they are taking assessments also. Even communication skills, they are going on well in most of the colleges. But I felt this is the procedural skills is the one which is a challenge. So I thought I have given a guidelines for some of our teachers to prepare a video, instructional videos. I'll share 3 slides on what are the guidelines I gave them in preparing the instructional videos. This depends mostly on what is the skill which you have chosen. For example, if it is an ophthalmologist, okay, it is fine. Ophthalmologist can prepare a video. But as you expressed, the examination of the abdomen or chest may be most difficult. And also that depends upon what you are teaching. If suppose you need a small kit with a thread and suture, you can do it off online teaching. But if it needs a more complex model, for example, examination of the abdomen can also be taught online, but if you need a mannequin for that, whether if it is an hostel or a house, if they do have a mannequin, it is fine. So I prepared few guidelines. I'm going to share it in few minutes. Simple procedures such as knot tying or suturing, etc., need a task training models. Task training, it could be some plastic sheet and a needle holder or something like that. This can be shared to the students or sent to the student. Instructional video takes through the steps of demonstration. As we know, in the cognitive part is there in the procedural skill. This cognitive part can be taught online. Now coming to actual procedural skill, which will be taught to the student, the first step of this procedural video should consist of demonstration with deconstruction. So the comprehension, that is, trainee talks through the trainee and trainee does. This is very important part. This has to be done synchronously. The other steps can be done non-synchronous. Whenever time he can see the video, the learner. But this has to be done at particular time, synchronous with interactive session with the trainer, right? The next step, that is performance, the trainee does can be recorded, and this how he can record. Simple recording devices such as laptop, cell phone, or headgear, something can be used which can be recorded. That is the procedure what he is doing. Trainee does performance, and learner can repeat this performance with feedback till attains a predefined level of competence. So instructional videos allow the learner to learn and see them repeatedly at his convenient time. And videos can be watched in small groups and break rooms, and instructional videos will promote students-centered, also self-directed learning. So what I have prepared is, I have prepared some guidelines for the people who are trying to teach this performance skills, what we have seen like ECG or anterior nasal packing. These things are being done by in our colleges also. They are trying to do something, preparing a video and send. So what I suggested them is, when you are preparing a video, it is not like that. You have to prepare a video which consists of all these steps which involve, as you know, cognitive part, comprehension part, performance part. So all this has to be involved. This is what I have shared with all my people, and hope that part may be useful for you. Thank you. Thank you.
Thank you very much, Professor Shalom. Quite a few things to think about that we should come back and speak about shortly. But now the last speaker in this foursome is Professor Thomas Chacko from Believers Church Medical College Hospital in Kerala, India. So is Professor Thomas Chacko with us, able to show? Ah, there you are. Yes, thank you. Can you share your screen, Professor Chacko, please?
Is it visible? Is the screen visible?
No, it's not just yet. We can hear you.
Okay.
There we
Now?
are. Yes, we're now seeing your shared screen. Thank you very much. Over to you.
Good evening, everybody. It gives me pleasure to be part of this webinar. listening to all the experiences shared across the globe. And I will also be sharing innovation that evolved out of the need because of this new pandemic, which has never been there in our generation. So it's about Facebook Live. See, when the COVID pandemic broke out, the government thought that if we can quickly separate and segregate everybody, then after the incubation period is over, then the disease will go away. And so lockdowns were announced, and suddenly students had to leave their hostels and rooms. And in that situation, unfortunately, has continued for more than 4 months now. And so what the students did and could take, they did not anticipate it would be this long. So what they took was only their mobile phones home and a few of essential things. But we took advantage of the only resource that they have is their mobile phones. And they are always on the social media, and they are familiar with that. And so the Facebook Live for clinical teaching was initiated. So live clinical rounds were telecast, and recording also happened, and the recording was also made available asynchronously. So it is the advantages of this Facebook Live style of clinical teaching is it's easy to create a Facebook page. Within the group, there is privacy. And the recording, live recording, as it happens, the recording device, the camera memory is not exhausted. And sorry. Obstacles to overcome: initially all did not have a Facebook account, so they had to overcome that, which is not a problem. And then the question came, everybody is busy managing COVID cases, so who will do the recording? And we had some students who were available in campus who stayed back and said they volunteered to do the recording, accompanying the doctors who were on rounds. So it's a student initiative. It's sustainable, and in the future we have the possibility of continuing this, where the senior students can teach and mentor the junior students for clinical skills in the form of near-peer mentoring. So this short experiment got over because even those students who were left behind in the college campus, they also left for home. And so we could not do a proper detailed study, but it's a proof of concept, and the Facebook page is live. And only thing that what we could have done better is what Dr. Saravana Bhavan mentioned earlier in this webinar, that debriefing and briefing sessions should be included, and the learner must receive feedback on their learning experience. So a much more structured way of learning, and shorter videos with narrative briefing for students to practice. We have to encourage them to receive feedback and the faculty to give the feedback and give the assessment. So that those elements need to be built on what has been started and was working well. And it is also important that this learning experience must be linked to the learning management system, and whatever feedback and performance improvements is received must get recorded in their learning management system, and in turn the student learning portfolio. So it gets recorded because now everything that is being learned will be over a period of more than 2 months more, at least. And so it is important that it gets institutionalized as in the form of a learning management system and the portfolio. What we realized was the faculty reluctance to participate because one, they were not familiar. Some of the earlier speakers also mentioned they are not familiar with online teaching, online facilitation of competency development, and competency-based medical education itself is new to the current faculty. And on top of that, making them to teach online together with, that is, they have to balance their regular clinical activity. So it's a tough ask, but once we make them knowledgeable and comfortable and show them the exemplars, then it will be possible for them, for more of them to get into the groove and start facilitating the learning of the students. It would also, many of them have also expressed the wish that they could be helped with creating virtual patient cases, capturing teachable moments on video, and providing feedback on students' assessment and performance. Ours is a new medical school, and so all these systems and hardwares are not yet available other than the simple learning system. We are using the Google platform. So, but many of the earlier speakers mentioned about how can we leave real patient exposure, how can we certify the graduate without that and all. We have to remember that it's a long, the continuum of competency development is long. So we could start with building the core knowledge and some of the skills which don't require actual patients, simulated case scenarios and history and all. So slowly over this continuum, we can progress. And then finally, when there is no more COVID, hopefully soon, they can go in for hands-on patient care. So my advice to others would be go for social media platforms because the bandwidth required for that is less. It is student friendly and on handheld mobiles. It needs to be linked to learning system which will record their progression and provide an opportunity. We teachers must provide an opportunity for the students to practice and receive feedback. And it is also important to stick to the scheduled curriculum, which brings order to the learning process. Otherwise, there is confusion what should happen. So there was a scheduled curriculum prior to COVID. As far as possible, the faculty must adhere to the curriculum and try to convert and attempt methods which you use online and simulated methods. And when we have your recording of this webinar, it can be shared so that ideas and good practices from all over the world will convince our faculty that they too can do it.
Thank you very much. Thank you. Thank you, Professor Chaku. That was, again, a very nice journey from looking at videos to going through simulation and then being videoed in the real setting. I think the questions that are coming up from the other participants is back to the ethics, you know, particularly that this is in real life clinical setting, students are taking videos to teach others. What did you actually, or what did they actually record, and how did you cope with the patient confidentiality, consent, and ethical issues? If you could just answer very briefly on that point, please.
Yeah, we need to sensitize the faculty who are because it's an actual live round with the clinician taking the lead, and the students are only recording. So the faculty will raise the flag if there is a issue of confidentiality and things like that.
So did they actually record patients in the ward round?
Yeah, it was recorded and only circulated within the group who are members of the face group, close group. It's not available for viewing outside the student community.
Thanks, Professor Chacko. I'm sure that will stimulate some thinking. That would be incredibly difficult to do in the areas that I have worked in and work in now. And indeed, there's a complete ban on students using their mobile phones for recording anything to do with patient data, including videos or photographs in the clinical setting. So you see straight away how that doesn't necessarily transfer to other cultures, but certainly things to think about. And if it could be set up in a slightly different way. The trouble is, whenever we set up mechanisms to protect patients' consent, confidentiality, and ethical issues, it is a huge barrier to teaching in that way. But great for getting us thinking. Thank you very much. I think we're going to now move on to the next four. Oh, sorry, I'm going to ask Ali to speak about the survey. And just before I do that, I'll run through the running order of the last speakers so that people can be organized. It's going to be Dr. Mutiso first, then Professor Fernando, and then Professor Madrigal, and then Professor Porter, and then Professor Sharifpour. We will actually have 5 for the last group. So, and that will be the last, and then some final discussion. But over to Ali to discuss the responses to the survey.
Fantastic. I'll cover the responses first, but I'd like to say that Professor Sharifpour has been replaced by Professor Irani Khan, the former president of his institution. So we have a huge privilege of welcoming a man who actually visited the Global Health Academy last year. So we've had 414 responses, as you can see, to the survey that was sent out to you. There's been some mixed opinion upon the role of video consultations. You can see that there's a mix of video consultations and clinical placements going on in your institutions. You can see that video clinical consultation skills. Some of you are providing observation of consultation, but the majority of you are giving both systemic teaching and observation of consultation. So in what settings are the clinical skills being taught in your institutions? You'll find that remote clinical case teaching by far is the biggest form of teaching, and you've got clinical simulation skills labs. It's good to know that 49%, nearly 50% of the respondents have clinical simulation skills labs in your institutions. So how many of you felt that clinical skills teaching was ethical? The vast majority of you felt that it wasn't ethical if that was the only form of teaching students clinical skills. How many of you are working in institutions where students are being given opt-out options? It appears that there's an even spread. Has PPE been made mandatory for students to wear for all or some clinical placements? In the vast majority of institutions, yes. Is your institution providing scrubs to students? You can see that the a fair majority is, but there's still 40% of you working in institutions where scrubs are not provided, and likewise PPE as well is not provided in institutions in which 40% of yourselves work in. So I'd like to thank you very much for responding to the survey, and it clearly does open up questions about institutions where PPE is not being provided, scrubs aren't being provided, whether it's a resource constraint or whether there is thinking actually still to go in that. It would certainly open up a lot of ethical questions. But it is actually interesting to see that different forms of clinical teaching delivery are actually occurring out there. So thank you very much for your time, and I think we'll continue with the speakers. If anyone has questions relating to the survey or in the context of the survey, then certainly put your hands up and use the chat boxes. Thanks.
Thank you very much, Ali. I realize there's some people with their hand up now. Could I ask those, Dr. Shantus Satpathy, is it a question related to what Ali was speaking about? Yeah, could you perhaps type in the chat box? And also Dr. Geeta Fulapalli, it would be really useful if you could type in the chat box, and then we could move on and pick up your question from there. Thanks. So we're moving on now to Dr. Kavalani Mutiso, who's speaking from Aga Khan University in Nairobi, Kenya. Thank you for sharing your screen. That's great. Over to you.
Okay, good afternoon.
Hello.
You can hear me?
Yes, very clearly. Thank you very much.
Okay, so I'm assistant professor. I'm actually a radiologist in my clinical practice, which is a bit unusual for someone to be interested in medical education, but I do have an interest. So these are my brief bio, and I have to say a special appreciation to two of my colleagues who assisted me in answering your questions, because they have more, I guess, clinical experience with their residents. So just as a disclaimer, our setting is a bit different. We do not have medical students. So we're currently not offering undergraduate medical education, but we're offering postgraduate medical education. So we have residents in training, but obviously, you know, they go through a very intensive training program in the time they're with us. So in a way, we have to deal with the same challenges as you would with possibly medical students. So moving on. So what did we do and why? So I would say very early on in the COVID pandemic, individual faculty took the initiative to raise awareness of the seriousness of COVID. I think anyone who's been following the COVID pandemic would know that things in the predominantly, I guess, the sub-Saharan African demographic took a while to pick up in terms of the infection rate and also the deaths from COVID. So it took a while for governments to act versus, I guess, in Europe and the US, as well as our overall death rate has actually never gotten as high as I would say, majority of the rest of the world based on number of infections. So quickly, the faculty who took initiative formed a task force to disseminate to work on and disseminate policies, mainly to ensure that things would continue to run in the institution, in the hospital, as they did, as close to as what they did previously. So this included wearing face masks for all staff, and then making PPE mandatory for patients, particularly patients that were suspected to be COVID positive or were COVID positive. So in terms of our training and teaching of the residents, simulation exercises were conducted for everybody involved in any kind of clinical care where it was felt they may be involved with COVID patients, and we involved the residents in those simulation exercises, so to ensure that they were always well protected. And wherever possible, all educational sessions that did not require hands-on demonstrations, sorry, I feel I've got this right in your, were moved to online platforms, which were essentially arranged by the individual departments. The main one that I'm aware we are using is the Zoom platform. In the event of hands-on demonstrations for clinical teaching that involve patients, we were limiting the number of people by a bedside to 2 to 3 where possible. However, more or less everything has continued. Teaching has continued on all wards and clinical areas except the COVID ward. So we created a designated COVID ward for the admission of known COVID patients or suspected COVID patients. And actually in the last few months, the hospital has actually had a policy whereby any elective admissions will require COVID tests at least 48 hours prior to admission. Before I move on to the next slide, I would just like to add a bit of background of our setting. We are a private hospital, university hospital, and we're very well resourced. So we don't necessarily represent what would happen in other public hospitals in the region. So certainly we had access to online platforms. Our residents generally didn't have issues with accessing internet, and they've been still able to come. We haven't stopped any teaching or training, or they haven't been sent home for periods of time. So we did our best to continue things as normal, but obviously with the awareness that COVID has become part of our lives. So if I'm just going to move to the next slide. So what went well? I think the individual faculty taking the initiative and raising the awareness of the seriousness of COVID early on, despite the lag in cases we saw in this part of the world. Faculty volunteering their time to research on how to maintain clinical education safely during the pandemic. Reenactments for the faculty and the residents of COVID scenarios or patients with potential suspected COVID or with COVID, and then the increased utilization of online tools. What could have been done better? So we did still have challenges about getting the appropriate personal protective equipment. There were challenges with shortages very early on with the same, and also with other necessary equipment or substances for sterilizing, etc. And then we also experienced challenges and some limitations from online learning. Occasionally there were connectivity issues, as we've seen with other presenters on this webinar. And then for me, because a lot of my education or clinical education as a radiologist is, we are predominantly online now, is gauging my residents' participation of what I'm teaching them, because it's very hard to see if you still have an engaged audience. What my clinical colleagues said is that as much as the online tools were good, there's some skills they just could definitely not teach, like empathy, good communication online. So, we had to they still had to maintain a significant clinical teaching for the residents. What we would advise others, I think simulation exercises, apologize for, are vital to the success of such a situation. And I think everybody should just be kind to each other. It's a new world we're living in, and thank you for your time.
Thank you very much. Very interesting. And it's amazing that we've got this far through the morning, and I think you're the first person who's mentioned the difficulty of audience participation, and that's something that we've really noticed in online teaching and learning, and maybe something we can pick up in the discussion at the end of these 4 presentations. Thanks very much, Dr. Mutiso. Let's move now to Professor Fernando from University of Kelaniya in Sri Lanka. Dr. Fernando, are you able to share your screen and can we hear you?
I think we've lost Dr. Fernando. He was here all along.
Yes. Shall we move on and come back if he returns?
Yes, let's do that.
So Professor Rex Madrigal from the Philippine Society of General Surgeons, Manila, the Philippines. Are you with us, Professor Madrigal?
Yeah.
Yeah,
Can I
great.
share my screen, please?
Great. Thank you very much. We're seeing your screen now, and we did hear you. Please, over to you.
Okay, good morning. Good evening on our side.
Yeah, are you able to speak a bit louder? Sorry to interrupt you.
Yeah, okay, good evening. Can you hear me well?
Yes, you're still quite faint. If you could come closer to your microphone.
Okay. Can you hear me now?
It is better. We'll concentrate.
All right. Okay. All right. Good evening, everybody. I'm Dr. Madrigal, and I'm going to give you updates on changes on clinical teaching during COVID times, Philippine setting. Philippines is quite unique due to the more than 7,000 islands with the 3 big island groups in Luzon, Visayas, and Mindanao. So much so that there are a cluster of cases in one island and none in some. I can only share our experience in the island of Luzon, specifically at Naga City. Okay, what did we do and why? We canceled all face-to-face and shifted to online learning using Zoom until September 1, 2020. That means on Tuesday, there will be face-to-face. We follow first the directives of our interagency task force on COVID-19. And with those directives, we also follow the guidelines from the Association of Philippine Medical Colleges Foundation, which is actually in charge of our postgraduate interns. The platform that offers convenient packages and affordability was adopted, and in our case, we adopted the Zoom platform. Okay, my apologies because I have to include this. This is not included in what I submitted. There are some instructional modifications given to us by APMC, which is number 1, waiver of elective rotation. There will be reduction of number or length of clinical rotations. There are reduction on required skills. There will be implementation of best practices in flexible learning and modification of internship course objectives to help achieve program or learning outcomes. There will be 3 types of intern rotation. The individual intern may choose from the 3 types of rotation. Number 1, there can be straight physical rotation depending on the readiness of the hospital. Number 2, there can be straight flexible learning mode with participation in the hospital's telemedicine service. But most will adopt a 6 months online flexible learning and 6 months actual physical rotation or some other combination of rotation offered by the hospital. What went well? Well, Zoom package accommodated about 100 slots for each learning sessions. We were able to interact with the students prior to our September 1 face-to-face. The Zoom platform offers flexibility for our schedule and a lot of materials available as what shared by previous presenters, teaching students how to go about with physical examination, which we adopted and hopefully prepared these clerks for the actual face-to-face. What could have been better in our locality? There are problems of connectivity due to inherent issues in our local service providers. There are bandwidth supply factors affecting video demonstrations, and in our area, electrical supplies, which sometimes students were cut off from participating in our Zoom lectures. What we would advise others is, as what the other professors are telling us a while ago, to innovate, There are plenty of materials available in the internet that may be applicable in your setting. So that ends my presentation. Thank you very much.
Thank you very much, Professor Madrigal. That was a good summary. I'd like to just move on and we'll come back and discuss all of them. So now I think instead of Professor Sharifpour, it's Professor Abdul Fazal Iranika. Sorry, I may not have pronounced that properly. Iranika, who's here to speak. Can we hear you and can you share your screen with us, please? And you're speaking from the Qom University of Medical Sciences in Iran. Hello, yes, I now see you. Hello.
Professor Irani Khan, yes, wonderful. Please unmute yourself.
That's good, we can see your screen now. Over to you.
Hello.
Hello, we can hear you.
Can you watch me? I haven't.
We can see your desktop. It's a beautiful picture of someone running at the edge of the sea. So I think we'll be ready to see your slides, Professor.
Good evening, dear professor. Good evening, dear professor, and hello to all of my dear colleagues who are present in this webinar. On behalf of myself and my colleagues at Qom University of Medical Sciences, I highly appreciate your worthwhile efforts in improving educational programs in this critical situation. And thank you for the opportunity to participate in the webinar. Would you please share my slide, please?
We're doing that just now.
Okay, thank you.
Next slide.
Next slide, please. Okay.
Please go ahead.
Okay.
Your slide.
Yeah, I have looked.
Can you see the slide? Would you like to speak to that one?
As you know, thank you very much. As you know, this crisis was a surprise, and perhaps nowhere in the world was there prior preparation in various fields. Therefore, in the first stage and first days of the crisis and the epidemic of the COVID, in order to prevent the staff from getting infected, we had to suspend all of training activities. And after a few weeks, about 6 weeks later, after our recognition, the first cases, we restart the theory classes virtually, restart of clinical training, of course, at limited level, and only for the same day hospital duty, and continue to suspend all of the workshops and gatherings into the hospitals and the class at the university. At third stage, gradually, with the cautious restart of some educational communities and exams, with the strict observance the hygienic principles, and due to the fact that an important part of the training in the second stage was not done well as we expected, and according to feedbacks were not appropriate. Next slide. What went well, according to adaptation of professors, students, and teaching staff to the new and current situation and condition, gradually we improve the condition. Applicants and teaching facilities improved little by little and gradually, and working with them more easily to be extended. The organization of training programs and exams is getting better gradually in this current condition. The next slide, please. And what could be better? These important processes haven't completed as expected. Transferring educational concepts by professors, students effective learning through cyberspace, and the evaluation process of this task have not found expected efficiently. The effectiveness of the medical education, the way the exams are conducted. The current training space and facilities are not yet fully adapted to the new conditions. The next slide, please. And about what we would advise others is prepare to suitable, purposeful, and logical strategic plan for medical education in this in the current condition and situation, based on these backgrounds and backbone of each center, according to capabilities, needs, objectives. And another advice is continuous monitoring of education process and creating a smart think tank in order to identify problems and shortages, make appropriate modification as needed. And another advice is upgrading educational spaces and facilities in order to benefit more and better in this in current situation. Next slide, please.
That's the final slide, Professor?
No, another one.
Oh, right.
Okay. We have to, I have to add that we have established other programs, including video recording in different issues, in different topics, and different disciplines. And my colleagues have made placed these recorded videos into the network of the university, which are accessible all of the times for students and residents to use them at home. In addition, we have regular morning report using virtual space, mostly WhatsApp, and we have to accept this bitter reality that unfortunately we would remain in this condition and in this situation. We have a commitment to improve the virtual education using such training and using such knowledge by these webinars. So we need to we ask you to continue this collaboration in order to improve virtual training. Thank you very much for your efforts in this regard.
Thank you very much, Professor Ranaka. Those last thoughts about how you've laid out planning and then monitoring and continuous quality assurance, it's a cycle we all know for any education, but this new world has certainly brought it back to the fore. And I'll be quite interested to know after our next speaker, who I think may be the last, to find out what everyone is thinking with respect to formal training versus anecdote versus just getting on and trialing it yourself. What has everybody found most useful? But we're now going to hear from Professor Daniel Porter from Hsinchu University, Beijing, China, and we are going to be able to hear from Dr. Mondal after that briefly, because you'll remember she wasn't able to speak at the time of giving her presentation on the jigsaw technique. I believe now that her sound has returned. So I'm going to hand over to Professor Daniel Porter. It'd be really nice to hear from Daniel. We used to work together a few years ago in Edinburgh, but he's now in Beijing, China.
Daniel, we've also got your slides up as requested by you, but we can't see you anymore. Oh, there you are. Fantastic.
We've got the slides, but do we have Daniel?
Yeah, it's interesting, Helen, isn't it? I mean, the bandwidth issues, there are all sorts of environmental issues that make online learnings, which actually reflect in this session how challenging online learning is to actually deliver.
Exactly.
I'm here now.
Yay. Hello, Daniel.
Hello, Daniel.
Over to you.
Thank you. Neil, Helen, Ali, colleagues, thank you for this chance to participate in this wonderful conference. First, let me explain what we did in Tsinghua University. We were the first in the world to experience COVID for obvious reasons. And our government dusted off the old policies which were successful in eradicating SARS 17 years before. And indeed, the leader for government advising of COVID has been the very same individual who was responsible for SARS eradication, Zhong Nanshan, who incidentally got his MD in respiratory medicine in Edinburgh 40 years ago. Yeah. The policies that we had to follow were top down, and we had no choice. We were either part of the solution or part of the problem, and that went for students as well as staff. The Ministry of Education is responsible for student tuition, for the graduate and undergraduate tuition, and the Ministry of Health for residents and interns. And there were some conflicts between the two with regards to when individuals could return to their bases. At the time of the outbreak, just at the point of Spring Festival, students returned to their hometowns, often thousands of kilometers away, I guess similar to the situation in India. Tuition was paralyzed. It was paralyzed on purpose, and the universities did not make any differential between medical students and other students, chemists, art students, and so forth. And they were told effectively, you graduate with what you've got, go home, stay clean. If you're coming back in the next semester, then we'll be ready for you. So huge resources have been placed in getting ready for the next clinical year, the next university year, which will start, of course. For interns and residents, we could start to teach these doctors and senior students from April onwards because of the success of the eradication program, and our hospitals were clean from that point. Ali, next slide, please. Almost all the teaching hospitals were clean hospitals. There were only 3 COVID hospitals in the city. And from April, we were able to teach with the same program that we had before COVID because there were no cases in our clean hospitals. For those students who were home, enthusiastic faculty delivered online teaching, but this was entirely under their own initiative. And it was difficult to get enthusiasm from the students who felt that they were going to graduate anyway. What was the point? We had faculty development programs instituted to be ready for the next semester, which has been really a program of producing hybrid classroom technology ready for whatever the fall may bring, which of course could involve the second wave. But at the moment, students are returning and they're ready to start their new clinical year. Next slide, please. What could have been done better? We had no existing plan for teaching. I think that if we were to, if the government was to look at this again, then they would ensure that we had an existing plan so that the students who went home had more than they did get. We could have provided clinical teaching and exams for students from April onwards if we'd been allowed, but we hadn't that privilege. So it was only independent action from an enthusiastic faculty that maintained any informal contacts with students. Next slide, please. Clearly, the aim for a zero infection or near zero infection in hospitals is a valid and useful result if we can achieve it so that clinical teaching can continue at a normal level. We advise that flexible, workable hybrid teaching plans for the next academic year based on unpredictable lockdown levels should be considered by medical schools. Thank you.
Thank you, Daniel, for that very succinct and clear overview. Fascinating when you've been at the very heart, the very beginning of the outbreak, and seem to be coming out the other end. So that there's hope for us, but there's still challenges for around another wave and whether we'll all be ready. We've been caught on the hop, but are we really ready for recurring waves? That's to be seen. I think we're now going to hear from Dr. Mondal very briefly about the Jigsaw experiment. I think this is focusing on student engagement, which would be really interesting since it's been highlighted by at least one other speaker. Dr. Mondal, are you able to come on screen and can we hear you now?
Yes, thank you very much.
Great. Could you quickly run through?
Yes. So I am Dr. Tanushree, and I am very grateful for giving me an opportunity to speak upon my experiences with the Jigsaw technique. And I thank the University of Edinburgh and Dr. Helen, Dr. Neil, and Dr. Ali for giving me this opportunity. So what we did is, yes, so this is what we did. We had actually done one cross-sectional interventional study. We know that in the era of COVID pandemic, it is very difficult to take the traditional classes. So we had planned for an online class, and this was of two types. One is the online class that where we involved the Jigsaw technique, and the other was the online class that was traditional in the sense that it was asynchronous, like the Google Classrooms. So we had divided them into 50-50 students. We took the institutional ethics clearance certificate, and we validated the tools and pilot tested on 10 students that were not included in the study. So informed consent was taken, and as you can see in the right hand side, we had taken the students on randomization, and we divided into two groups. After a week, they were again crossovered. Now in each session there was a pre-test followed by a post-test after the learning session. Now at the end of the fourth week, we also conducted a reassessment test that was done to find the retention of the students. And at the end, faculty feedback was taken, and following that, a data analysis was done. Now, next slide. Yes. So what went really well was that, as you can see, that there were two responses. One is from the student side and one was from the facilitator's side. So it was found that it improved the communication skills and the teamwork among the students. They were not shy at all, and the knowledge they thought could be imparted into the community. They can be translated into community, and the gaps in knowledge were much less, and it improved the scores in the assessment. Similarly, the facilitators, they also thought that it improved the group dynamics, and they thought that this must be incorporated into teaching. So what we find is that we are talking about competency based medical education these days. So we know that we talk of building an IMG, Indian medical graduate, with the professionalism. He must be a clinical person, he must be a good communicator, he must be a leader and a lifelong learner. So these were all achieved through this kind of a teaching. Next slide, please. Yes, so we can see the difference in the post test as well as the retention test that was done at the end of the 4th week, and there the tests were highly significant. Next slide, please. Next slide. Yeah, so I just want to tell at the end of my slide that we know that in this new normal period where the online teaching is very essential. So what I found is that online Jigsaw teaching learning method was far better, and it really reaped a good results rather than the online traditional teaching learning system. So at the end, I would rather sum up with the saying, we know that necessity is the mother of invention, but where invention is not always possible, yes, necessity is obviously the mother of both invention as well as innovation. Thank you again for giving me this opportunity, and I give my best regards to everybody and all the esteemed speakers. Thank you very much.
Dr. Mondal, thank you very much. Thank you for persevering. It was really very clear that time, so it just shows you the vagaries of the internet earlier on. Dr. Mondal, really interesting that it's almost like a PBL you've been running, but instead of all the students going away and reading all the same material, or at least the same subjects, and answering the same questions, you've been dividing it up. Why do you think that that works better than just listening to staff giving lectures?
It is a very good question. Actually, Jigsaw actually involves the participation of the students. The teachers here are just the facilitators. So as the name suggests, that Jigsaw here, the students are broken into groups from the main group to the expert group, where they discuss on different topics. And after that, they are brought to the home groups so that the topic that they had been learning for 5 minutes or 10 minutes, they can discuss with their peers. So it is a way of learning as well as dissemination to the peers, and it increases the accountability of the students. So it is very good because in the long run it improves their concentration, and it also improves in what we say as a lifelong learner. So it motivates them. Yes, and there were certain, I want to say that there were certain things that we wanted to improve. That is, number one is internet connectivity, because we had done it is in Zoom, and that is into certain breakout rooms. We had divided the students into 2 breakout rooms. So it becomes a very difficult thing when, internet connectivity is poor. And number two, we had done on students, only 100 students. If we could have done for 250 students, because in each semester we have 250 students, so that would have been better. And time was obviously one constraint. Thank you.
Thanks, Dr. Mondal. Can I just ask you one follow-on question from that, which is how, when a group comes back into the total jigsaw, that one piece, that little group of students comes back with new knowledge, which they're going to share with the whole class. The easiest thing for them to do would be just to deliver some didactic teaching, and that's when everyone else switches off. How do you teach them to actually engage with their peers while they're presenting that material? Because that really is the skill, isn't it?
Yes, that is another very good question. It is yes, when the students they are told to perform or to deliberate what they learned after this jigsaw session. Now it may be that the other students they might not be interested. So in that case, there could be an interactive lecture session. I mean, everyone can take part into it. And on the other hand, there could be question answer sessions also. So that can arouse the that can keep people awake and just not listen in a one way. And obviously there are other things. I mean, there are, like, we can also perform some role plays also, so that depends upon the topic of interest. Yes.
Thank you, Dr. Mondal. It certainly stimulated my thinking to say, not only do the students need to look stuff up and become experts in that subtopic, but they've got to come back and deliver it in an interactive way to ensure the whole class actually engages. That might be the one of the goals of the session. Thank you very much. So I'm going to hand over to Neil and ask him to summarize or bring to the fore any questions, comments and thoughts from the chat that's been going on as we've been listening to the speakers, because I want to capture that.
There's been a really wide range of things coming up. One of them, of course, and it's tribute to 200 people for staying here, because we're now half an hour over our advertised time, and some of the chat has been about this issue of Zoom fatigue, or global online fatigue syndrome. I quite like the GOFS abbreviation. Thank you for that, everyone. It was interesting. It was really good to get back to the jigsaw issue, because it has been touched on a couple of times, but I think many of us have this experience of giving online teaching, and are the students all engaging? Many of them switch their video cameras off, and ways of ensuring engagement. And I did just put a question in the chat about using team-based learning online, which is where the students read some material or watch some material beforehand, and then you give them some really quite difficult challenges which they have to solve in teams. The very best way to do this is for you to be able to speak to the teams around or sit at the same time, and they can speak within their group while listening to you. Now, short of having two different technologies running, that is a bit of a challenge, and I've just been trying it. So that would be very good. Generally, the idea of making the students do things is what we all want. It's what we would do in the clinical setting or in the physical setting. We'd look round for the people who hadn't answered questions. That's harder online, and I think I'm hearing it, although not everyone has said it explicitly, but there've been a few comments up the side about it. I think the other theme that really came up was people have loved hearing the tricks that people have used for doing things with students at home that they could normally only do face-to-face. And one example was demonstrate how you would examine that abdomen on a pillow. Even better, of course, if you have got a human you can demonstrate it on. And we haven't gone into it very much, because mostly we've been talking about earlier skills, but the concept of that Ali, I know, has engaged in, of actually getting the patient to examine themselves. This is not something we've started teaching yet in any significant degree, but certainly locally we're talking more about it. So you get the patient to demonstrate all their knee and hip movements if they're complaining of pain in the leg, and you get the patient to examine their abdomen and show where it's tender, and so on. These are not currently on our syllabus, but the longer this goes on, I think the more we will need to train our students in that kind of technique. Helen, was there anything else? I'm very conscious of time. We're going to have a really interesting session in a month on that other really thorny question about assessment. But I think there really is, we'll have a conversation afterwards about whether there is a way that we could collect very short accounts and photographs of people's techniques, many of which have been talked about today. And I've got a helper who's going to go through the video of this recording and try and pull out the themes and the individual examples of good things that have been done. Ali, should we hand back to you?
Does anyone else have a question? Does somebody want to come in and add any comments? Because we've still got over 200 people in this meeting. So please come on camera and raise your hands. Anybody? I'm very conscious that this session has overran by half an hour. We have Dr. Vamshi Kondal. Would you like to come in, Dr. Vamshi? I see you've raised your hand. Okay, I'm unmuting you. Wonderful. Please come in.
Hi, thanks for giving me an opportunity, and it's a wonderful session. We are doing pretty similar in my medical college. I'm head of the department in pediatrics, but we find difficult because some of the times they are not in the video mode, so they escape. When the questions are asked, they're there, but then they don't show up. So it is very difficult, and as we are finding different ways to reach them and teach them, they are also finding newer and newer ways to escape. So that goes on. I mean, it's a continuation process. Thanks for giving me opportunity.
Dr. Vamshi, that's a comment that's really close to my heart, because
thank you.
At the end of our term, I was finding myself speaking to a blank screen, and it was as if nobody was out there. And I think that adds to the online fatigue. And I think we may have made things more difficult for ourselves by saying to our students at the outset to switch off their cameras, to mute their microphones because of bandwidth concerns, and then they've got into the habit of sitting in the dark background. We're now thinking that we're going to set housekeeping rules, which is put on your videos and be seen to be there and to engage. And we're going to go back on what we had said before. I wonder if other people are thinking of setting house rules like that.
Thank you.
Dr. Abutahin, I don't know if you can speak. Can you? Can you?
Thank you. Thank you. I agree with you. This is a problem. But I have another point. It happened also even with the classical lectures in the session. Maybe we have some students who are sitting there, but they aren't there. So it's not only the problem of the Zoom or the online teaching. They may be sitting in the lecture room, but their mind is away. They are playing with their mobile. So it's not only a problem in the Zoom. So it happened everywhere. This is what I want to comment. Thank you.
Absolutely. Can I ask, there's other people with their hands up. Dr. Geeta Pulapalli?
Dr. Geeta, could you please come on camera so that we can locate you? Can't find Dr. Geeta. We'll see if we can find you. Yeah. Okay, so we've unmuted you. No, it doesn't look like we can. We've got Dr. Geeta.
What about Professor Mudassir Aziz Khan?
Yes, he made a very interesting point, didn't he, about the bio bubble, very similar to sports, where you have international cricket teams visiting one another and staying in a hotel on site. So that obviously raises the question, should students and doctors be housed on one site? would that be seen as a form of infringement of liberty?
That would,
yeah. Well, it would if it went on for 2 years.
That would be very.
In reality, I think attempts have been made in the clinical environment to create bubbles, but it's too hard. The patients coming and going, the staff are working shifts, they have families, the doctors' rotas don't coincide with the it's really, really hard. It's easier in your early years in university, and I think that some schools are attempting it to some degree, but I've yet to see whether it'll be effective.
Professor, could you come in on that? Professor, you're unmuted. You can say, would you like to say something about that? Do you have an experience of the bio bubble being practiced?
No, not exactly. But I was just wondering if sports could adopt that. So even in institutions, we could adopt for our teaching and training purposes, especially in the hospitals, bedside teaching, where you cannot really substitute with any other method that is available in the world. Hands-on training and the experience of getting, feeling the patient and getting face-to-face and talking to the patient is an experience in itself, which is very much a part of the teaching and learning experience in the bedside clinics. So that is why I would have thought we could still manage to hire people from maybe extra people if we need extra faculty, and also make sure that the students could get into batches, so that batch by batch they could be exposed to the bedside learning and teaching experiences. So that is what I thought could be done in a much better way.
It's a very attractive proposition, but it would probably take a lot of resource in an economy, world economy that has been hit very hard. But of course, medicine will always remain a priority because we'll still have to produce high quality doctors to deal with that. Neil, Helen, would you like to come in on that?
Just to say that we've thought about it and can't see how it'll work, because even in Birmingham, where we have a lot of local students, they're going to commute across the city and live in multi-generational families, that I don't think we can keep them in a bubble. We've thought, but we've given up at the moment.
Right, I think we're heading to close over here. We've got Dr. Datta. Do you have a couple of sentences to add? You had your hand up briefly. You are unmuted.
Good evening, sir. Yeah, good evening, sir. Good evening. Actually, going through this whole session, it's been so nice to hear experiences from all across the globe. I'm presently in Malaysia and I'm an anatomist. So how I'll relate to what we are doing here is, this is the same way I try to put across my classes to my students, not being harsh on them, the microphone for bandwidth reasons. But, you know, we really can't be too harsh on them. Because how I try to keep their interest is, every 15 minutes, you know, you pop up a quiz, like you ask them questions and how to connect it clinically. Like suppose I'm taking classes on neuroanatomy. It's quite difficult for them to be engaged for more than an hour or so. But if I try to show videos on clinical cases, on stroke, on hemiplegia, on examination of muscles. So we have found that breaking up this teaching content into smaller modules keeps them better engaged. So without being harsh on them, without judging them too much, being kind, and it's okay if some of them disappear by the end of the class and things are going on. So this is what I wanted to say, and such platforms actually, you know, give a lot of impetus to us to try and implement this tricks to keep the students' attention. So what really struck me was formal training to anecdotes to, you know, somehow managing the show. If we are able to streamline this, then online teaching learning process becomes quite effective. Thank you, sir.
Thank you very much, Dr. Datta. Syriac Job, do you have any points to add to that?
Yeah. Good evening all. I am Dr. Syriac Job, Vice Principal of Government Medical College Mancheri and a Professor of Forensic Medicine. I used to take Zoom classes. So it is mandatory. The students should record it in the notebook. They should write the summary of it. And I will ask some of the students to send the photo of it. Second thing, while taking toxicology classes, I have given them the name of 5 plants. So they have to find out the plant in the locality. After that, they have to take a photo along with the plant. And after reaching home, they have to prepare a project work on that plant. So as a mentor, I will direct how to prepare it. That way I am doing for the last 2 months at our institution. That's like good presentation, a good interaction I had, excellent. You organize everything so that I got a global idea how to proceed with the medical education.
Fantastic. Thank you, Dr. Job. I mean, I'd like to say to all participants that, encouraged by today's participation, I'd like to create a forum on the Hippocratics website where you can all post your ideas, as Professor Turner has suggested, and these ideas can then be shared widely. Professor Subramaniam, I think, one final comment from you and before we close.
Thank you very much, sir. It was a wonderful session all through and which gave a lot of inputs. But I wanted to add one opinion of myself. That is the training of psychomotor skills is what I feel is we need to work more on in that area, because we can explain, we can demonstrate, but the practice becomes the crucial. And many a times how the student did perform the skill and how to evaluate online, I think is a challenging job in the changing times. That I wanted to add. I think there should be more focus on training of clinical skills both for undergraduates and postgraduates in terms of e-learning. That's what I want.
Fantastic. Final comments from Helen and Neil.
Yes, building on what's just been said, I was also thinking that it's almost like an inverted Miller's pyramid, for those of you that are familiar with Miller's pyramid. We are doing quite well the teaching of theory, even in the time of COVID. We're using online materials, we're using recordings of videos and talks. We, of course, even have very good textbooks nowadays, which we might not have had 2 generations ago. So we're doing quite well at teaching theory. We're living that life. We know how to teach communication skills, even online. I wouldn't yet say most of us are doing that. We haven't mastered it, but we know how to do it. And we have seen some examples and we're experimenting with it. We're even demonstrating to others how to do it. But the actual doing, as you have just said, we know the theory of how to teach the psychomotor skills, but very few of us have really cracked it at all. And I agree, that really is our challenge, and particularly where we involve the patient and all the ethical issues of consent and confidentiality. So, in a few months' time, it would be really nice if we came back and focused on the teaching of psychomotor skills in an ethical way. Would be good, I think. Thank you.
And as you each crack those challenges, posting on this forum would be brilliant, because everybody wants to know.
Yes, I think this forum has demonstrated the power of anecdote and short stories. I mean, we've all probably been invited to go on training for online teaching, and we've done our bit, but actually hearing the anecdotes and the personal stories of those who have tried it and to some extent failed and learned from that failure and developed it further is very powerful. So thank you very much for all those stories. Over to you, Ali.
And I hope you agree. It's been really touching to see people from so many countries across the globe coming, making their time and actually sharing learning. I'd like to actually name each speaker and thank them. But unfortunately, in the interest of time, I can't. But a big thank you to all the speakers. A big thank you to over 280 of you who were here to share the learning. I have to say that we'll be back for the assessment session, as Neil said, in about a month's time. We'll send out more details about the date, and we would encourage all of you to come back or to contribute in some way or the other. And of course, those of you who want to speak, yes, you're most welcome, because I think assessment has been put forward as the most tricky area in this COVID environment for people to deal with. A short note on behalf of Liz Grant. Liz at the Global Health Academy has been developing a suite of programs to train doctors in primary care. Now, I hope you all agree that with primary care being part of the universal health coverage agenda of the UN, and the fact that from COVID-19, if you like, the health infrastructure has been put under a huge amount of stress. You will probably have heard of stories of people who've not been able to access doctors, and hence there is this need now of looking at medicine from a completely different prism, to move away from the advancement of specialisms and rather focus on what the majority of patients need, which is good primary healthcare. Haven't we all heard these stories of people who are actually dying from not being able to access hospitals? I think it's a powerful need. So we hope to be there in January to discuss ways of training doctors for primary healthcare on behalf of the Global Health Academy, in addition to these sessions on medical education. So thank you very much, all of you. Yes, it's a hard time, COVID-19, floods, hurricanes, power shortages, all sorts of things. And yet, you've all braved that and come here to be with us. Thank you. Be safe and see you soon. Thank you very much, each one of you. Thank you all. Bye-bye.
Goodbye.